So far the talks have been described, many points have been highlighted, but one point is that the intravitreal injection should be done very slowly. There should not be any rapid rise of intraocular pressure. It causes reflexes, and the reflex is not an adequate situation for doing an intravitreal injection, because while you are dealing with a malignant case, they may come out outside the eye, and several experiments have proven that if the injection has been performed under low intraocular pressure condition, the reflex is not there, the risk of endophthalmitis also reduces, the risk of vitreous weak syndrome also reduces. So that point all of us have to remember. Why I am telling it make a revolution? Because in the laboratory we use a petri dish. On that petri dish we put some amount of inoculum, and we can make so many wonders, starting from culturing bacteria, making a cell line, so many things. So intraocular environment is like a petri dish. If you go inside, then nothing is there. You can directly inoculate some material as you want to do, and it can have a wonderful effect on the retina and the choroid. Several experiments have proven that. So I am sure that in future the intravitreal therapy will make a change, and all of us have to know what is intravitreal therapy. Now regarding the infection, one is very important thing, the aerosol. Now we have the laminar flow for dispensing laminar flow in the OT, but we encountered endophthalmitis in 3 cases. And on cause analysis we have found the one very important thing, while doing injection nobody should talk. It is never necessary to talk, because it is proven in some of the experiments that aerosol contamination is a very significant factor for intravitreal injection. Now, greetings from my institute, and thanks to Dr. Assis for giving me the opportunity to speak and take part in his instruction course. Now, vitreoretinal disease are referred to topical as well as systemic medication. It is because of specific environment of the eye. Blood aqueous and blood retinal barrier makes the eye a relatively sequence-driven organ. Pharmacological agents from the aqueous humor cannot act on the vitreous cavity because of forward stream movement of the aqueous humor. So whatever oxyfloxacin we inject into the anterior vitreous anterior chamber, nothing is going to happen in the vitreous cavity. The vitreoretinal disease are refractory to topical. So to overcome the barrier, direct drug injection in the vitreous cavity is important. It took a long time to realize pars plana being the safest route of entry to the vitreoretinal cavity. Till date, there is no known gold standard for therapy or drug delivery system for this route. We have to understand the pars plana of the child and pars plana of the adult are different. In fact, in the child there is no pars plana. Whatever injection we make in children, it is pars plicator, the distance is and less. Now, intravitreal pharmacokinetics, we have to understand how the drugs are cleared from the vitreous cavity. The drugs spread through the vitreous cavity at the same rate as they will through a free solution. Now, mathematical module of drug diffusion in the vitreous has been estimated. The vitreous body considered as a cylinder. Using fixed second law of diffusion, 3 major pathways of drug elimination has been considered. One is aqueous drainage, the hydrophilic drug, then retrocoroidal scleral membrane clearance through lipophilic, and the lens both. So drug dispensing has to be made accordingly, and an intravitreal injection can be made effective to the anterior chamber also, anterior segment also. Drug decay rate is greater in diseased eye than in a normal eye. The first intravitreal injection was started in 1911 for repairing the retina. 1940, it has started intravitreal injection of penicillin for treating endophthalmitis. So the history is long, and we have come little bit ahead of development. The present day broad indication of intravitreal injections are diabetic retinal disease, macular degeneration, etc. There are some disadvantages of intravitreal injection. or repeat injection. The high frequency of intravitreal injection, short-term action of the drug for chronic disease, risk of endophthalmitis or pseudoendophthalmitis, compromising protection to the other eye and other organ, and the local application. So this is the need for development. The techniques and technology of intraocular drug delivery system are developing. Every year new experiments are coming up. The new strategies are to improve the safety and maximize the efficacy of the therapy. The presently used drugs are antibiotics, steroid, anti-VEGF and immunosuppressive agent. Intraocular drug delivery system, including sustained release delivery platform for intravitreal administration, will provide safety, continuous and long-term efficacy. Non-biodegradable implant and insert, biodegradable inserts and many microparticles are in evolution. These are some intravitreal therapy which are approved and which are waiting for approval. And the list is constantly adding up, and we can be sure that in near future many of the therapies will be coming up and will make a paradigm shift of managing different ocular conditions. Many biodegradable formulations, including different shapes of rods, nail-like plugs, disc or micro or nanoparticles are also investigated, which are awaiting approval for clinical use. The most developed biodegradable implant is Ozurdex, the dexamethasone intravitreal implant. First line therapy for macular edema following retinal vein occlusion, both central vein and branch vein, and its indications are expanding. So this is the Ozurdex injection. It has already been shown, and this is the method of injection. When the drug is injected in the vitreous cavity, the pellet which is there inside the eye, rod which is inside the eye, it starts disseminating the microparticles. It disperses into the vitreous cavity just like a drop of inoculum in the media. This incorporates into the retinal tissue, particularly in the retinal vasculature, though the exact mechanism is yet to be known. And retinal vein occlusion, the blood vessels are affected, the blood vessels become leaky, the fluid content comes out, inflammation sets in. So when the Ozurdex is injected, it stabilizes the wall of the blood vessel, controls the inflammation and improves the circulatory situation in the retina, and the retinal edema subsides, and the secondary effect due to tissue logging into the vitreous cavity disappears and the vision improves. So this is briefly the mechanism of this medication. So many medications are in trial so that we can give a long sustained effect. This is an Ozurdex implant inside the vitreous cavity 1 month after injection, and this undergoes biodegradation along with the time. Initially it remains opaque, then it becomes translucent, gets fragmented, and finally it becomes smaller by 2 months time, and disintegrate into the tissue. Now the maximum concentration is found in 2 months. So you can well imagine when the Avastin is injected, it action lasts for about 2 weeks. But here you can see up to 6 months a drug delivery is possible with the existing mechanism. It is an example. Upper one is a central vein thrombosis. With 1 month it is resolved following an Ozurdex injection. The second one is a branch vein occlusion. It similarly resolves after injection. But there is recurrence also in our hand. We are the largest user of intravitreal Ozurdex in the eastern part of the country. But we have to keep in our mind that it can recur. So it is not the absolute and final treatment of retinal vein occlusion. Moreover, we have to consider the natural resolution. In this case, no treatment has been given, it has resolved. It is a branch vein occlusion. Along with the time, many branch vein occlusion get resolved. So after seeing the case, immediately you should not think that Ozurdex is to be given. So many other points to be considered, and the natural recovery over the treatment therapy you have to consider intelligently in all the situations. Intravitreal chemotherapy is probably will be the recent advance. In 2014 publication, when there is an intravitreal seed resistant to all the treatment, the intravitreal malformation can be treated, can be successfully treated, and they have given a protocol for injection also. After injecting, triple freeze-throw cryolysis to be done before removing the needles so that extraocular extension can be prevented. Now there is a lots of controversy in a malignant eye injection to be given or not, but it has been proven with a 30 gauge needle it can be given without even the cryotherapy, the extraocular extension can be prevented. Non-infectious uveitis, many drugs are coming up. Now this will open a new horizon, enzymatic vitrectomy. Ocuroplasmin is a recombinant truncated form of human plasmin obtained from microplasminogen. If it is injected, the vitreomacular traction is released, and intravitreal injection 125 microgram of ocuroplasmin can resolve vitreomacular traction and can resolve the macular hole. So many of the cases, the macular hole will not require treatment, it will be remaining one injection only. Now regarding newer devices, newer devices come to make the injection speedier and safer. It is intravitreal assistant. The device is like this. From the side port, the injection can be given with a very much accuracy. It does not require any eye speculum use. It is having an anesthetic effect. It can prevent reflux also. Next injection, what I have told, next injection method is the guarded injection device. What I have told you, the aerosol technology, the aerosol contamination is an important factor of infection. So a guard has been developed. This guard flips into the tip of the injection needle. So long the needle is introduced, it collapses on itself so that any aerosol contamination can be prevented. So, in conclusion, intravitreal therapy is an important and routine part of vitreoretinal practice. Newer drugs are evolving for safe, practicable and long sustained result. Newer technologies are evolved to make clinical practice more easier and safer. Thank you for the patient hearing.